All right, I think we can go ahead and get started. Good afternoon, good morning, depending on the time zone that you're in right now. Welcome to this virtual poster session for the Society for Digital Mental Health annual meeting. My name is Aaron Jones, and I'll be moderating this session on enhancing mental health among marginalized or underserved communities. We'll be hearing from 8 presenters today. Each presenters will have up to 2 minutes to share their work, followed by 2 to 3 minutes for audience questions. You're welcome to submit your questions in the Zoom chat at any time during the presentation, and we encourage you to ask a question for each presenter after each presenter finishes. Please remain muted during the presentations, but you're welcome to unmute yourself if you'd like to ask a live question after each presentation. All right, if there's no questions or anything, we'll go ahead and get started. So our first presenter is Olive Huang, presenting on social determinants of health are associated with differences in acceptability and engagement with a mindfulness app, moderation by gender, sexual orientation, race, ethnicity, and educational attainment. So Olive, when you're ready, you can, the floor is all yours.
Thank you very much, Aaron. So I'm just going to go ahead and share my screen. And I just like to make sure that this looks fine. Amazing. All right. So to start off this really important conversation today, one important theme raised by many speakers today is advancing digital mental health care in underserved communities. But one foundational question here is whether there are differences in engagement with digital tools before we can make sense of any outcomes. Specifically, I focus on mindfulness apps and whether there are differences in acceptability and engagement by social determinants of health based on gender, sexual orientation, race, ethnicity, and educational attainment. So we use data from a clinical trial with treatment-seeking adults. They tried out the AMDTX mindfulness app for 1 month and follow-up. We collected data on adoption, ratings of acceptability, app engagement by the number of exercises and meditation minutes completed, as well as study attrition. So what did we find? These graphs above here showcase our engagement findings. To break this down, the y-axis shows the likelihood of engagement. Orange bars are above 1, shows that they were more likely to engage than the blue bar, their counterpart, the reference group, and less likely to engage if it's below 1, while the x-axis breaks the likelihood down by social determinants of health. So across both outcomes, we found a similar pattern. Women, so sexual minorities, and below college-educated individuals were more likely to engage with the app than their counterparts. However, BIPOC individuals were less likely to engage than their white counterparts. If you look at the table here, there were no significant differences for app adoption, acceptability, or attrition, which shows that overall, the app was adopted and acceptable across people with different social statuses. But one specifically exciting aspect about this project is some evidence of better engagement in some underserved communities, and it may be promising to support these individuals with mindfulness apps. So thank you, and I welcome any questions or comments.
Awesome, thank you. Great timing too. Thanks, Olive. Does anyone have any questions for her presentation? I had one, Olive, question about the social determinants of health. I know you looked
Yes.
at the gender and race. Did you also think about looking at age to see if that was possibly different among the gender and race of people?
So that's a great question. So we did look at age, but we did, that wasn't the main variable of interest, but this is a secondary analysis of our main paper, and we did find age differences in the engagement of the app. So we did co-vary for age in our analyses, but we do recognize we did have a pretty big age gap from like 18 to 66, and the younger adults did show greater engagement, kind of what was echoed in like the keynote speaking session, but more like the kind of digital literacy and perhaps lack of the initial push. But that was kind of how we took into account age in our project.
Okay, thank you. And we have some questions in the chat. So first one is, why do you think BIPOC individuals were less likely to engage with the apps?
Yeah, so that's a great question, and we're still trying to like look into why that is. This app, first of all, is a general app. It wasn't tailored to like the needs of these different underserved people from underserved communities, and perhaps BIPOC individuals. Same for other like communities, like the different stressors they encounter in life might be less targeted or like less able to be addressed with like the meditation practices like supported through this app. But like that's definitely a future direction that we hope that future research will be able to tackle and understand and better support BIPOC individuals.
Yeah, definitely going to like the idea of like cultural adaptation and what that looks like for each community. Okay. And then one last question we have is, did you find that attrition was impacted by the social determinants of health?
So we did not find any differences for attrition.
Okay. Well, again, thank you so much, Olive. We appreciate your work on this. All right. So, oh yeah, go ahead. Very good. Okay. So next we're going to go to our second presenter. It's going to be Kanza Faisal, presenting on iterative development of a culturally adapted CBT conversational agent for mental health, a focus on Pakistan and South Asian LMICs. So the floor is yours.
Thank you, Erin. Is my screen visible?
Yes.
All right, perfect. Thank you, Tyler, for the thumbs up. Right. So Pakistan is the most underdeveloped nation, which is amongst the top populous countries. It's the fifth populous country. And a digital tool in this space is something that is really needed and is really being appreciated by the users. So one of our platforms to introduce the idea of digital mental health for people was Dil Ki Baat. And a subdivision for that was that a web-based platform for kind of a chatbot was created to kind of support that web-based platform, which was Dil Ki Baat. And then this chatbot named Isa is the first culturally adapted CBT chatbot, a conversational agent. It was designed to bridge treatment gap for South Asian communities. One of the strengths for this chatbot is that it supports both English, which is the official language of the country, and Urdu, the national language of Pakistan, making it easier for users to kind of think and talk in the same language. Whatever they think, they don't have to translate it before putting it into a conversational agent. And then it starts with some easy built-in prompts to encourage users with something to begin the conversation with, provides users with empathy and validation, serves as the first experience for a lot of people because mental health is something that is really stigmatized. And a lot of people, they find it really important because it offers them a route to actually find therapists in their region. So the methodology we adopted behind the development of this tool was that it is an AI-powered conversational agent developed on contextualized, culturally adapted CBT. Python powers AI model training and backend logic. JavaScript supports front-end development. Open source, it is basically on open source AI, and it is a web-based. It has a web-based interface. So it has been around 6 months now, and we have had over 6,000 users since it was launched. And about 10% of the users have been recurrent and have engaged for at least 2 to 3 sessions. From the qualitative feedback that we got, people liked that it was non-judgmental. They could talk to it. They wanted their urgent needs to be supported by it. They expressed symptoms of depression, anxiety, interpersonal relationship difficulties, career-related issues. A lot of parents wanted to use it for management of their children with neurodevelopmental issues and behavioral issues. Other usage that people adopted it for were because they cannot really, therapy everywhere is expensive, and in Pakistan too, the accessibility and availability, and after that, the affordability. All of them are almost impossible for people. So people appreciate it for being free and for being an affordable service. Um, they prefer the format to be inclusive of more voice-based features. And a lot of people wanted to use it as a tool to kind of educate themselves. Like a lot of students, they wanted to adopt it for their own professional growth. And a lot of people used it as a self-help tool. Currently, it is just an MVP, a minimal viable product. And through this product, a lot of around 20% of people have approached the original platform Dil Ki Baat to get therapy from real time therapists, from real life therapists. So, in conclusion, ISO's rapid user adoption, positive feedback suggests that people really want it. This is something that needs to be developed and will have positive results for people. However, it remains an early stage prototype, and a lot of work still needs to be done on it. No clinical efficacy evaluations have been done on it so far. And the future directions, one of the main thing that we noticed was that a lot of people that were using it did not um, know how to get the best out of a conversational agent. So I think that is something that we really need to train people on, how to ask the right kind of questions. And then we plan on introducing voice accessibility features because people cannot afford a lot of things. So WhatsApp interface integration and making it offline are both very important for deployment of such tools in an underserved population. And that's pretty much it. Thank you.
All right, thanks, Kanza. We have a couple questions we're going to get through. First one is, do you think that having the platform be AI-based helps with problems related to stigma? For example, people may feel more comfortable talking to AI rather than a real person.
Definitely. I've used it for myself too. I feel like there were questions that I went to asking real professionals. They went into the nitty and gritties of things before coming to a point. With AI. It was just speedy and you could just ask the relevant questions. And it genuinely did, because I'm a clinician myself. So even for me, it becomes even harder to ask a clinician that, this is the problem that I'm facing. So definitely it helps with destigmatization.
All right. And our next question is, how did ISA determine which users potentially needed advanced help?
Okay, so we flagged some commonly used terms that are culturally relevant, um, because it uses both formats, English and Urdu, both language formats. So the words that we commonly people use, we flag those words so that if they are the words that are highlighted in any conversation, it would just redirect the users to Dil Ki Baat platform so that they can get help for their problems, for more serious or advanced kind of problems.
Our next one is, were there geographical differences in use, urban versus rural residences?
So we did not do because it's just a prototype, so we have only um, kind of launched it in more urban areas yet. We haven't really promoted it in kind of like the rural areas. Yeah.
And our final one is, do you have information on who were more likely to use this agent? They wonder whether the chatbot differs in its ability to help with different levels of symptom severity. And did you need to program this?
Do you have more information on who were more likely to use this? Okay, so I think because it was, even though it was promoted across all social media platforms, but I feel like that almost nearly 50%, that's a guesswork because we haven't really done the actual factual numbers with this. But from my guesswork, from the data that I've seen, I would say that a lot of psychology graduates and students, they have been actually using it a lot more than the actual patient population that we intend for for the platform to kind of reach out to. And that is why I thought that, because the resources are so limited in Pakistan and there are no formal trainings really. So I thought that this was being the first culturally adapted CBT tool. This was something that a lot of professionals or early career graduates were trying to use.
Okay, thank you so much again, Kanza, for this presentation. So we're going to keep going to our third one.
Okay.
So next, we're going to have Joan Alibosin. They're going to present on peer support need and format preferences of people with multiple sclerosis. So Joan, when you get a chance, you can share your screen and the floor is yours.
Thank you. Can you see my screen?
Yes, I just don't see any slides or anything. Okay, now I see it.
Oh, perfect. Thanks, everybody. So I'm going to be talking a little bit about peer support in MS over here in Ireland, and I'll be explaining a little bit about their needs and preferences for support. Now, overall, people with MS experience a lot of psychological challenges or distress, and um, in general, peer support might help just because peer support is an opportunity for people, with in the same situation or going through the same condition to provide information as well as practical advice or emotional support, as the case may be. And so we had a mixed methods survey that was co-designed with public patient involvement. We had a panel of about, I think there were 7, as well as staff of MS Ireland. Now, MS Ireland is the MS Society that advocates for people with MS needs here in Ireland. And so we had this survey that aimed to explore peer support needs, engagement, experiences, and preferences of people living with MS in Ireland. Overall, we had about 218 people participate, and majorly they had relapsed and remitting MS. And about 60% of them were able to walk unaided. And what we did find was that about 2/3 of them expressed the need for peer support. However, 2/3 also did not engage in peer support, which was a bit surprising. And what we did find that was interesting was that people never really engaged in person compared to online options. We found that the need for peer support as well as peer support engagement was predicted by living with more disability or at earlier stages of their diagnosis with MS. And overall, people expressed a preference for social media options or messaging apps such as WhatsApp and Telegram, and in Instagram and X. And we did find, interestingly, that about half of the people, 48%, agreed with its potential to provide emotional support benefits. Now, what we did overall find in summary was that peer support is rarely engaged in, though needed, particularly following diagnosis with multiple sclerosis and with increase in disabilities. However, small groups and informal in-person meetings are preferred, although online formats are popular. Thank you very much, and I'm happy to take further questions.
All right, thank you. And we do have a question in the chat. So what are some important considerations that researchers should make when developing interventions for people living with MS?
Definitely, people with MS need to be involved in the co-design. There are a lot of opportunities for people to interact in terms of peer support, but there are also other digital formats that are available for their use. I think one thing that is lacking is the fact that a lot of these options are developed without their actual participation in the design. And because a condition like MS is so varied, people have very wide range of experiences, and it's important that they are included as well, all through the stages of design, whether it's for research or whether it's for interventions themselves that are targeted at improving their psychological well-being.
I'm sorry, I forgot to take myself off mute. I had a question of was emotional support the greatest need for peer support, or was there a need for information sharing or other needs to be met through peer support?
Yes, even though I've not presented this in this poster, we did ask if they had, their agreement with the fact that peer support could meet informational needs as well. And we had about the same proportion of people expressing that it was beneficial to provide information overall.
All right, thank you. And our last one is, did you evaluate whether their PWMS had a family and formal caregiver? Curious how that might play into the need for peer support.
Yes, interestingly, we had about 70% of people either living with family or friends, and we had about 80% of people in a relationship that participated. And despite this, there was still a very high need for peer support, which explains the fact that even though people have some support from their family and friends, peers can provide, I would say, an outlet where they can share experiences that are unique to them, amongst other things as well.
Great, thank you so much, John. We really appreciate it.
Thank you so much.
Of course, yeah. So we're going to go to our next presenter, Tyler Smith, presenting on establishing a youth research collaborative to validate machine learning classifiers of social media data, leveraging human-centered design and youth research partnership.
Thank you for the introduction, Erin. Can everyone see my screen okay?
Yes.
Perfect. So I'm going to start with some context for this project. So loneliness and perceived isolation are linked to disproportionately higher rates of mental health problems in marginalized youth, such as youth who identify as Black, LGBTQ+, or Latinx. These youth may turn to social media to get social support and connectedness that they can't find offline. But this increased use may also expose them to interactions that make them feel lonelier or more isolated. One way that we can classify interactions that represent these risk and protective factors in social media content is through machine learning algorithms, but these algorithms are often based on content from majority populations. We established and trained a research collaborative with marginalized youth to identify loneliness, social isolation, social support, and connectedness in social media content donated by marginalized youth, and to validate machine learning algorithm classifiers of the content that was donated. Our lab partnered with 3 Pittsburgh-based community organizations who serve Black, Latinx, and LGBTQ+ youth to help us form the collaborative with 14 youth ages 13 to 21. Our collaborative began in February 2024. We used human-centered design activities to create working definitions of loneliness, social isolation, social support, and connectedness that married research-informed theory and the youth's personal experiences. These definitions serve as ground truth that the youth use to validate machine learning algorithm classifiers. Over the past few months, the youth have practiced validating machine learning algorithm classifiers using computer-simulated Instagram direct message data. They are now moving on to validating machine learning algorithm classifiers of social media content donated by study participants. The youth's feedback is given to our colleagues at Georgia Tech, who developed the machine learning algorithm so that they can make its classifications more accurate. We hope that this work will lead to the development of social media-based interventions that reduce risk and increase protection for marginalized youth who experience loneliness and social isolation.
All right, thank you, Tyler. Anyone have any questions about this presentation? I had a specific one about how was it challenging trying to incorporate the aspect of human-centered design, which is like focused on the people and their experiences, and trying to balance that with integrating it into a machine learning, which is more numbers-based and not really focused on that? Like, how was that process?
Yeah, it's been super interesting. When what we first started doing with the computer simulated data was our partners at Georgia Tech used ChatGPT to come up with fake Instagram DMs, and the youth thought ChatGPT was very inaccurate and did not actually capture um, the way that youth speak online and what things that they talk about. So but that's the whole reason why we have this youth collaborative, is to sort of check the machine learning, because that part can only do so much. And that's why the human element is really important, because we want to be developing algorithms that actually reflect people's lived experiences, because we know that the machine learning can only do so much and is often based off of data that is biased.
And could you elaborate on how this could help build social media-based interventions?
Exactly. Yeah. So, for example, if you take a look in the middle, these are some examples of ChatGPT simulated direct message data. But with the youth, we have them sort of identify what parts that they think are um, expressing loneliness, social isolation, or one of our other concepts. And we think that knowing what types of social media content have these labels will be able to help us sort of use social media data itself to identify when people are feeling lonely or isolated or connected. So, for example, maybe in the near future, we would be able to look at someone's Instagram data and identify sentences or identify emojis or identify things that say, okay, we know this person is exhibiting loneliness. And then maybe we could give them an intervention right there in the moment to help them feel less lonely.
All right, thank you. And just to be aware of time, I'm just gonna get one more question. How did you go about recruiting the youth for the collaborative?
Great question. So we partnered with three of these organizations here: Hugh Lane Wellness Foundation, Casa San Jose, and Proud Haven. They're all based in Pittsburgh. And we gave their staff a flyer that had information about the Youth Research Collaborative. They gave those to youth who they knew would be interested. So youth who maybe have participated in other advisory boards or had shown an interest in participating in research. And then they give us the information of those youth, and our team talked to them over the phone and gave them details. And then we invited all the youth that were interested to join the first session. So we've retained most of the youth that have first started with us, but there has been some dropout.
All right. Yeah, thank you again, Tyler, for this presentation. So we're going to go to our next one. Sophia Beltram Chana, the role of automatic automaticity in the associations between daily social media use and the mental health outcomes among Hispanic and Latinx dementia caregivers.
Thank you so much for that introduction. So I'm going to share my screen here real quick. Okay, so hopefully you're seeing that in your
Yes.
screen. Yeah, perfect. Okay. So my research is focused on Hispanic and Latinx family caregivers of individuals living with dementia. And so to give a little bit of context for this, so we know in general that relatives that are caregivers of people living with dementia have very, very high levels of stress and social network restrictions due to their caregiving responsibilities. And this, of course, puts them at risk of poor mental health outcomes like symptoms of anxiety, depression, and so forth. Specifically among Hispanic and Latinx caregivers, these risks are higher, given that cultural values definitely tend to emphasize more of this informal caregiving role. And they tend to face a lot of minority stress experiences like discrimination in medical settings, language barriers, financial barriers, things like that. So given this context and knowing that Hispanics overall tend to be one of the groups that uses social media platforms more frequently, we wanted to understand how caregivers specifically, given that there's this social network restriction going on already as part of their caregiving role, we wanted to see how social media plays a role in all of this, how maybe they are engaging with these platforms for coping resource or for informational resources, and in general, how the use that they are making of these platforms is affecting their mental health. And so for this, we recruited caregivers all across the US with a heavy recruitment presence from Puerto Rico specifically. And we asked caregivers to complete a baseline survey followed by 21 days of daily diary surveys, where we were just asking them about various mental health related variables and social media kind of use patterns questions. So how much time they are using social media passively, how much time they are using actively. And specifically, we were interested in this role that automaticity may play in basically in strengthening the habit of engaging with social media in the first place. And so we engaged in some multi-level modeling analyses with these variables. And what we found was that specifically in the relationship between daily passive social media use and depressive symptoms, automaticity was a significant moderator, such that at higher levels of automaticity, the positive association between daily passive social media use and depressive symptoms, they become stronger. So we think that maybe certain characteristics of automaticity, like maybe using without a clear intention or conscious awareness or putting much cognitive effort onto the use that you're making of these platforms, some of those characteristics may be fostering maybe patterns of disengagement and in turn make those depressive symptoms worse when engaging with these platforms. However, future research should definitely continue to examine what the underlying mechanisms driving those associations might be.
All right, thank you, Sophia. I'll give a couple moments for any questions. Okay, we got one. Do you think that this can be utilized to implement digital tools for the caregivers with strong social media use?
Yes, so that's the hope, right? So this is, to my knowledge, the first study that's looking at social media use patterns specifically in this population. And so what we are hoping is that by understanding how they are engaging with these platforms in the first place, we will be able to tailor specific content shared through these platforms to them in a more culturally appropriate and linguistically appropriate way as well.
All right, thank you. And is automaticity associated with mental health issues or other behaviors? For example, impulsivity?
Yeah, so I guess the theoretical models behind this usually put automaticity and self-regulation issues as both of them kind of working together to and this is, I guess, for context, this has been more so looked at in youth. So this is the novelty of looking at it in older populations. But in general, those models have, in theory, put together automaticity and self-regulation kind of working together to make social media use more of a problematic behavior in a way. So yes, there's been some literature that does support that type of relationship. In our study, we haven't yet been able to look at the self-regulation / maybe impulsivity aspect yet, but we would expect it that individuals that maybe are engaging with social media more frequently than the average caregiver may be also struggling with issues with self-regulation and impulsivity as well.
And our last question, what recruitment strategies did you find most effective for reaching and engaging caregivers in this work, given the time and resource constraints they face?
Yeah, that's a great question. So we've tried everything under the sun, I would say, including social media recruitment. So we created targeted ads and people would just receive those in their social media platforms. So that's a little bit of bias in the recruitment, but we also did get a lot of caregivers through partnerships with community organizations across all the US states. We basically would contact churches with Hispanic and Latinx kind of surveys or subgroup, or organizations that are specifically focused on caregivers or Hispanic Latinx community in general. So those two, I would say, were the most efficient recruitment strategies. One caveat to mention is that we are in Alabama. Like, the study is housed at the University of Alabama at Birmingham, which does not have a ton of Hispanic Latinx individuals in general. So other research teams working with this population have also seen success through community events in the locations where they have their studies housed, but that hasn't been the case for us.
Great. Thank you again, Sophia. And I really do like the aspect of using this population, because they're kind of considered like the sandwich generation, because they have children to take care of, but they also have being caregivers for their parents and possibly grandparents. But yes, so thank you, Sophia. We appreciate this.
Of course.
All right. So next we're going to go to Carmen Householder Padari. They're going to present peer support facilitated online cognitive behavioral therapy for substance use disorder, lessons learned from a peer support perspective. Carmen, oh yeah.
Sorry, I was having trouble unmuting myself. Can everyone see my slides okay?
Yes.
Okay, so despite the high prevalence of substance use related harms, the majority of individuals affected do not seek formal treatment. Digital interventions such as Breaking Free Online, which is a CBT-based therapy, are being used to bridge this gap through improved accessibility and responding to an increasingly online world. However, many individuals who interact with digital mental health receive little or no human support. Peer support, defined by support grounded in shared lived experience and the values of hope, empathy, and self-determination, may offer a valuable way to enhance engagement with digital tools. This presentation outlines the implementation of peer-supported, peer-facilitated Breaking Free Online within a randomized control trial. 197 participants were randomized to one of three arms, which were group peer support, Breaking Free Online, or individual peer support. And each also included clinical monitoring. The study design, assessment schedule, and peer support worker training was collaboratively developed with the input of an advisory committee that included lived experts and service users, as well as scientists and clinicians. 66 participants who were primarily diagnosed with alcohol and cannabis use disorders were randomized to Breaking Free Online with individualized peer support. And I personally provided peer support for 31 of those 66. While individual preferences varied, key themes emerged. Participants consistently reported that peer support improved their ability to engage with Breaking Free Online by helping them set personalized goals, challenge unhelpful thinking, and stay accountable, and also apply the digital content to their own lives. The biggest piece of feedback that I received is I would not have engaged with Breaking Free as much if there wasn't a peer support worker with me. Challenges that were identified included technical barriers, missed appointments, and the need to better define and capture meaningful outcomes. Many participants described personal growth and positive changes that were not reflected in standard digital metrics. Importantly, peer supporters themselves reported benefits from the process, including professional and personal development and the opportunity to provide meaningful person-centered care. And some integrating peer support with digital interventions like Breaking Free Online offers a promising scalable approach to substance use treatment. It brings structure to a complex discipline while maintaining the flexibility and responsiveness that peer support requires. Thank you.
Great, thank you, Carmen. So one question we have is, what was your experience like providing peer support to some participants?
It was quite varied, but I found it very rewarding. It was quite interesting when I first started with this. I thought that there was going to be quite a large issue with who it was reaching, and I found that there were folks that were really quite severe, and it was very empowering to work with them, but also people who were more in a maintenance phase of their life, and it was also quite supportive to them as well.
All right, and our next question is, was there much training needed for the peer support workers? And how were you able to recruit the peer support workers?
So training was, this is another project that we're working on, is adapting the training to kind of reflect the experiences of the peer support workers, because um, though it was great to set us up, there was a lot of varied need amongst the participants, and you couldn't provide that training to cover absolutely everything. So it was quite general, and then through kind of experience with interacting people, that was kind of the best training that we ended up getting. And for recruitment, it was through, I was hired through CAMH, so it was like the CAMH job board, and through with CAPSA as well, which is a peer support network at Ottawa.
All right, and just to be aware of time, we're gonna just move on to the next one. But of course, you can respond back to the other questions in the chat. We don't want to miss those. But yeah, thank you again, Carmen. We really appreciate it. So our next one is going to be presenting on do sexual and gender minority groups endorse different barriers and attitudes towards mental health treatment than majority group peers? And that'll be by Snigdha Kamarsu.
And Snigdha's actually sick today, so I'm going to
Okay.
be jumping in.
Okay. All right, thank you.
Yeah. Okay. Okay. Erin, I can only see you. Can you give me a thumbs up if you can see my screen?
Yes, we can see it.
Okay, great. Cool. So this project was done in Atlanta. We were originally we recruited to look kind of just generally at like acceptability of digital mental health and like what barriers people are facing to in-person care. And so for this poster specifically, we just kind of zoomed in on sexual and gender differences between majority and minority groups. And the scales that we used the APOI, Attitudes Towards Psychological Online Interventions, which there are a few subscales that you can see on the right-hand side here. So we use those to look at kind of people's attitudes toward online work, and we gave some like psychoeducation about what like an online CBT intervention would look like, and then they answered questions about it. And then similarly, they gave feedback on barriers that participants face to in-person treatment. So to like attending a weekly therapy appointment. And then we looked at that across answers to that across gender identity and then sexual orientation to just understand if we're seeing any differences in kind of how people interact with or have attitudes toward both in person and more virtual options. So for the most part, there was a fair amount of, I guess, equality in how people answered. So we didn't see a ton of differences, but the differences that we did see were kind of just indicative. Again, I think that like a lot of our work, that there's just like more nuance here than maybe we might have initially thought when thinking about virtual options, that it's this, great thing that can reduce stigma and reduce, like transportation barriers and things like that. But I think we're seeing that it might just be a little more nuanced than that. So for example, we did see, that for example, in this negative attitudes, that people who were genderqueer, as well as people who identified as other sexual minority identities, which essentially just means that they weren't heterosexual and they didn't identify as lesbian, gay, or bisexual, that those individuals were more worried about like not having kind of like the personal contact and that like more intimate relationship that you can get with a therapist. So they were more worried about that not being a component of, you know, a more self-led digital mental health intervention. But then on the flip side, you know, those same individuals were reporting greater confidence that those, you know, interventions could potentially help them. So kind of, you know, maybe some hope for those things, but still some concerns about, you know, what engaging with them would look like. And then similarly, in barriers to in-person treatment, we saw kind of some mixed results among the groups. You know, with some people, women specifically, endorsing greater stigma and emotional concerns, in this context referred to mostly being concerned about like the emotional effects of therapy and like what would come up in those contexts. And so we saw, you know, women having some more concerns about that than men. Didn't really see any differences across the gender minority groups in this. And then in the sexual orientation groups, we saw that the heterosexual group had like the most motivation to engage with in-person health services, and then sort of decreased from there. The lesbian, gay, and bisexual group had less motivation than heterosexual group, and then the other sexual minority individuals had even less than that. And then as far as practical barriers, we didn't see any differences, again, in kind of the sexual and gender minority groups, but we did see some significant differences between women and men as far as what practical barriers they're facing. So this data set had a lot going against it, to be honest, but I think it's just really important that we're super honest about like the challenges that these different groups might be facing, as well as like what isn't a challenge. Because I think maybe sometimes too we can get like really zoned in on like we have to fix, you know, maybe a certain access or something, and depending on who we're targeting, like maybe not, maybe they're okay with how things are right now. So I think this just reinforced to me like it's all about nuance. But that is, I'll just stop there.
Thank you, Heather. Really appreciate it. It's great content. One question we have is, were there any differences in outcomes, experiences between those receiving individual versus group peer support?
I don't think that's for me. I think that maybe was for the last presentation.
Okay. Oh yeah, that may be for the last one.
Yeah, no worries.
Okay, sorry about that.
No,
One we do
sorry.
have is, what are some strategies to address the attitudinal barriers, specifically with less motivation to engage in therapy?
Yeah, it's a great question. And I think a big thing here that we were, you know, somebody mentioned earlier too when talking about the AI, that ISA chatbot for the culturally adapted CBT, is that I think there's just like education, a lack of education to like, how do you use these things? What could you get out of it? I know with patients that I work with, there's a lot of questions too, still just about like, what does this even do? And how does this compare to going to therapy? And like, would I do both? Do I just do one? Like, how does this even work? So I think there's partially a lot of like psychoeducation that we can still provide, about, you know, where to go for different severities or different symptoms, et cetera. And then also like the great work that a lot of y'all are doing with like cultural adaptations. And I think things like that are also really important, and just making sure that we're, as therapists, I think too, those of us who are practicing also are, you know, focusing on and finding those more niche, perhaps like apps or outlets that might apply to more specific populations, rather than just promoting, you know, the more generally known ones that are, you know, not necessarily culturally tailored. So that's what I would say.
Yeah, thank you. Very important work that you all are doing with that. So next we move to our last presenter, last but not least, Madeline Esterer, Life Improvement for Teens, Lift, Engagement and Cultural Acceptability Findings for our Web-Based Trauma Intervention.
Okay. Okay, can you see my screen okay?
Yes.
Fantastic. Okay. Hi, everyone. I'm very excited to talk to you all today about Life Improvement for Teens, or LIFT. This is a web-based program to support post-traumatic stress in young people. It's a self-administered cognitive behavioral therapy-based intervention specifically developed for racially and ethnically marginalized folks, young people in their teen years. And so it's typically completed 7 modules over 7 weeks. So this study is looking at 24 participants who are in the US, age 18 to 19, and primarily Black and Hispanic Latinx. Who experienced a traumatic event. We also specifically included individuals who have experienced race-related traumatic events, so discrimination, racial profiling, accumulation of microaggressions, things like that, were our inclusion criteria as well, so I could understand their experiences with LIFT. So what we found is really varied engagement. So I'll walk through engagement and what we found related to cultural acceptability. So only about a quarter of participants who were given login access to LIFT as a part of our study finished all 7 chapters. In it, looking kind of more specifically, out of those participants who were given access to LIFT and logged in at least one time, a little over half, or 55%, did finish LIFT and also met what we considered to be the minimum dosage criteria to engage with LIFT, to conclude that they received kind of all of the core ingredients, CBT ingredients, you could say, of LIFT, based on how many minutes they engaged with the chapters and the percentage of videos that they had watched. So we also found really mixed findings related to acceptability, specifically cultural acceptability of LIFT. So you can see here in this table, we found a lot of positive and negative experiences through surveys and interviews related to people's experiences with LIFT, looking at usability, the burdensomeness of LIFT, or the cost, benefit, and cultural factors, specifically how LIFT can do better to support with managing race-related stressors, like I mentioned. So feel free to read through these quotes in the table. I'm just going to highlight the one in purple, I feel like really is one that captures nicely the nuance of this issue. So this individual said, "I know the Latinx community, there's a huge stigma around mental health, but I'm pretty open to it. So I guess me doing this program is already more just like me going outside the norms of my own culture. So I don't think there was ever a possibility for this program or any mental health program to fit into my culture. I managed LIFT on my own because I don't feel comfortable speaking with mental health with my family." So as you can see, this quote, amongst some of these other kind of positive and negative pieces of feedback that we got, was really helpful, showed that LIFT was really helpful for different folks in independently accessing mental health support for specifically anxiety, peer pressure, and grief. But LIFT can do a lot better at discussing microaggressions and also discussing how to face cultural stigma from folks in your family related to mental health. And so I'll leave it at that. There were definitely some limitations too here. My positionality as a white female researcher, and also the fact we had a really small sample size and a lot of engagement issues, which really limited the amount we were able to understand acceptability, and definitely missing some pieces of the puzzle there. But I included as well some QR codes here at the bottom right. There's a LIFT intervention guide if you're interested in learning more about LIFT. It has some school-based applications as well, because LIFT was initially developed and tested in a school environment with young people. And also some references and the website to access LIFT, since it is a publicly available intervention. So I will leave it at that and see if there are any questions.
All right, thank you, Madeline. Yeah, I did like how you incorporated the need for like more culturally adaptive material, as someone did mention, like just more information on microaggressions. So like moving forward, what are your ideas on like how that would look like in like another research study?
Yeah, that's a great question. I think just broadening the types of examples of different traumatic experiences, and like in the original study for LIFT, it like assesses information about people's traumatic experiences, but doesn't include like normalizing that like racial or ethnicity related stressors could be traumatic. It's kind of more implied, but I feel like it could be more directly stated when just providing psychoeducation about mental health and traumatic stress. And like, I feel like it could be more directly discussed in like the earlier parts of the intervention, but also when like going through an example of like social problem solving, right? And how that would look really different for like race-related stress or microaggressions, where there are like insinuated safety concerns. And I feel like that level of nuance could be just more directly addressed, and how that looks different, and normalizing that for people so they don't feel so alone in that.
Awesome. I think we got time for one more question. With adaptation already for REN and race-related traumatic events, do you see further need for advanced technology like AI for extra personalization?
Yeah, I do. This intervention unfortunately does not have that currently included in its development, but I definitely think there's a lot of room for that level of personalization to allow like more of that adaptation, since it may not be applicable to everyone. This intervention specifically is designed for racially and ethnically minoritized folks, and it does a really good job in a lot of ways. I want to make sure too I highlight that, but I think AI could help since we know it is so individualized to what those like specific mental health stigmas that you might face, right? That differs in different communities, and it might be hard for an intervention to capture everything. So I think AI could definitely be a nice way to allow that individualization to prosper.
Yeah, because now AI is like everywhere in the news, so it's like you can't
Yep.
really ignore it. But yes, thank you so much for this presentation. And I believe that includes all of our presentations for today. Thank you for everyone that made their contributions. If you'd like to follow up with any of the presenters, I'm sure there's ways you can contact them directly through the interface for Society for Digital Mental Health. Again, thank you so much for your time. We've learned a lot today, and I hope that you have an amazing rest of your day.